So now we're going to turn our attention to use of CAR T-cell therapy in patients with high-risk lymphomas, and we have actually 2 commercial agents approved in the setting. Fred, do you want to take us through some of the emerging data with axicabtagene ciloleucel?
Yeah, so axicabtagene ciloleucel, or axi-cel, is a CD28 costimulatory domain-based CD19 CAR T-cell therapy, and it was tested in the ZUMA-1 trial in patients, adult patients with relapsed and refractory, diffuse large B-cell lymphoma and its variants. And I think it's, before we talk about the results of that trial and the durability of results, it's important to look at the historical data in patients who were not treated with CAR T-cell therapy. So the SCHOLAR-1 was a large patient-level meta-analysis in patients who had had prior lines of chemotherapy and had not responded. So patients who had, at best, had progressive disease or stable disease to their last line of systemic therapy. And these patients were followed in both 2 large clinical trials and also 2 separate large databases. And those patients who didn't respond to their last line of therapy had a 26% chance of responding to the next line of therapy and a 7% chance of having a complete response to their next line of therapy. So that sets the stage for the historical data. The ZUMA-1 trial took those same patients and it gave them axicabtagene ciloleucel, and the response rates, the overall response rate was over 80%, and the complete response rate was over 50%, again, comparing very favorably to the historical treatments for these patients. Here at ASH this year, we now have even longer-term follow-up of the ZUMA-1 clinical trial with a 3-year follow-up, median of 3-year follow-up in all patients. And what we can see is that at a 39.1-month median follow-up, that the overall survival, the median overall survival, has now been reached at 25.8 months. So that's pretty impressive for patients that, compared to the SCHOLAR-1, where the median overall survival was 6.3 months.
So one of the criticisms of that analysis is that the patients that were described in the SCHOLAR-1 did not have to jump through any hoops of eligibility criteria, which the ZUMA-1 trial did, which could obviously bias the population slightly. But I think that, you know, some of the data we're seeing now in the real world kind of allay some of our concerns about that.
Yeah, so several different data sets in the real world or standard of care use of axi-cel. This is, of course, now an FDA-approved product. Were presented here at ASH. Dr. Mike Jane presented an oral abstract here looking at a large cohort of patients across 17 academic medical centers that provide axicabtagene ciloleucel for large B-cell lymphoma patients. And we see that, first of all, the response rates and with close to a year follow-up, the durable response rates compare very favorably in these patients. And in fact, on an intent to treat basis, at least intent defined as a patient who is apheresed for manufacture of CAR T-cell therapy, on an intent to treat basis, the results are still quite impressive and compare very favorably to the SCHOLAR-1 data set.
And Karen, I know you have a consortium as well. Would you like to comment?
Yeah, I mean, I think we're seeing the same thing. We're actually seeing that the number of patients that were apheresed and treated in the real world are actually comparable to what we saw on ZUMA-1. And it only amounts to, it amounts to a very small drop-off, and that's why the intent to treat analysis looks so good, because it is so comparable to what was seen on the ZUMA-1 study. But in our series, about 60% of patients would not have been eligible for ZUMA-1 for a variety of reasons. Partly because they received bridging therapy, which was not allowed on ZUMA-1, but at least 40% of them were ineligible because of organ function impairment and other parameters. And those patients did, when you put that patient into a cumulative, into a combined pool, the group actually does similarly well to what we saw in ZUMA-1.
Now that's a really, you bring up a really controversial area, and I want to ask Fred about this, but bridging therapy, which was not allowed in ZUMA-1, is used in all the other clinical trials with the Kymriah and with Lisa Captagine, Mariluz, also Fred.
So in our, again, 17-center consortium, which is complementary to the one you just described, I want to add one thing and then talk about the bridging. When we looked at eligibility for ZUMA-1, we defined it as at the time of apheresis, and about 45% of the patients in our data set, and it's close to 300 patients total, would not have been eligible for ZUMA-1. And the one thing that seems to come out of that analysis that predicts for worse outcomes in those patients is a poor ECOG performance status. So that's one area where outside of the clinical trials, patients do seem to do worse. It's not that they can't obtain remissions and durable remissions, but treating patients with an ECOG of 3 or 4 or maybe even 2 is something that really has to be considered carefully.
And we saw the same thing. That was the only thing that came out in terms of being predictive for response rate. We didn't look at that variable with duration of response.
And then we looked at bridging therapy, right? So on the ZUMA-1 trial, patients were apheresed, and then they had to wait for receipt of their CAR T cells. That turnaround time was on average 17 days, so it's relatively rapid. But in the real world, in the standard of care setting, patients are receiving bridging therapy, whether it be corticosteroids, radiation, combination chemotherapy, or more molecularly targeted agents. And we did an analysis in that 298 patient data set in the consortium and found that on univariate analysis, patients who had received bridging therapy had worse progression-free survival and overall survival. But when we performed, and that held on multivariable analysis as well. However, when we looked deeper, when we did a propensity score, matched propensity score analysis, we found that progression-free survival was no longer different when we matched for characteristics in the bridged patients versus non-bridged patients. And that's likely because the bridged patients were the worst patients. They had worse performance status, they had worse IPI, all the features, higher LDH, all the features that would suggest that they had more rapidly progressive disease, and they were the ones who were selected for bridging chemotherapy because the physician probably felt that they couldn't make it to the 17 days. That being said, on that propensity match analysis, the overall survival was worse in bridge patients. And there is a question about whether bridging should be given, but in my practice, I try to avoid giving bridging therapy unless I feel the patient can't make it that 17 days or 3 weeks.
Yeah, I think
What about your practice?
I agree with Fred. I think that we give bridging therapy when it's needed. However, we don't give it just to try and hold somebody to receive therapy if they don't have an urgent need for bridging. The controversy about bridging, which I agree with all the points, is it's either a surrogate for bad lymphoma, or it may be doing something to the microenvironment which potentially could be harmful to the CAR T cells. We don't yet know. There's no data to suggest.